ACOEM Patient-Centered Medical Home Implications for Occupational Medicine webinar. Today's program will provide you with a general overview of the concepts and rationale for PCMH, as well as review the important perspectives of employers and providers. Today's program is being recorded. There is 1.5 hours of CME and MLC credit for this program. You received a verification form with today's instructions, or you can follow the link that was in the instructions. No certificates will be sent to you, but your transcript of this and other ACOEM educational programs can be viewed and printed from the ACOEM website. Members and non-members can both view their transcript directly from the website. Today's program will consist of about 75 minutes of lecture with questions at the end. We will address questions as time permits and suggest that you submit your questions early for consideration. We are only accepting questions electronically. On this screen, you can see how to open the question box in order to submit your questions. This was also in the PDF file of your handouts you received with the instructions. This educational activities planners indicated they have no disclosures to be made. Regarding presenters, we did want to disclose that Dr. Fabius disclosed that at Thomson Reuters he receives salary as CMO, and at HealthNext LLC he has ownership interest as co-founder. Dr. Paul Grundy has received honorariums for speaking about patient-centered medical home for medical groups like the AAFP state meeting by both Merck and Pfizer. He has never given talks about products or services. Dr. Sherman has indicated no disclosures to be made. At this time, it is my pleasure to turn the floor over to today's presenter, Dr. Paul Grundy, IBM's Director of Healthcare Transformation and President of Patient-Centered Primary Care Collaborative. Dr. Grundy, you may begin.
Thank you very much. It's a great pleasure to be here with you today. I think this is an exciting time to be speaking to my parent college, the American College of Occupational and Environmental Medicine, about such an important concept. A couple of days ago, we learned about how reform is going to go forward, and now that that's behind us, and we're really going to have to transform ourselves to creating real value, this is absolutely key, because foundational to this is the concept of the patient-centered medical home. It's the very foundation that our administration is going to be building its future on. It was so declared by executive order to both the Veterans Administration and the DOD, and if you listen to the conversation with our Secretary of HHS, it's the foundation of how we're going to drive a transformation as we go forward. So I think this is a really important element. I did have the privilege of spending a couple of hours in the White House yesterday going over how this is going to roll out, and I think there's an extremely important role for the American College of Occupational and Environmental Medicine, as you know, we're really the interface between corporate America and the field of medicine as to kind of how this possibly could roll out. So thank you very much for letting me have this conversation with you this morning. So as buyers of care, we're a little less than half the spend now. For those of you who are big proponents of the single-payer plan, by definition, we just became it about 3 weeks ago with 51.3% of the spend in the public sector. But we as large employers are still a significant part of the buy, and what's clear to us is that we'll continue to be that for some time to come. We spend twice as much as any other nation on the face of the earth for the care we buy, and yet the value proposition of what it is that we buy is extremely low. We all know that. We're dead last. We're 19 out of 19 of the developed economies in terms of the value proposition of the care that we buy. And we're beginning to understand some of the reasons for that. We spend twice as much on heart surgery as anywhere else, but we have to, because we really don't have the robust system of comprehensive prevention and primary care. I was driving down the freeway the other day, passed a sign, and the sign said, "We do the best heart surgery in the state." And I went in and I had a meeting with the CFO, the CMO, the CEO, all the O's of that particular hospital. It's one where we do quite a bit of business. And I said, you know, we're not going to move another job into this community. We're finished. It's over. In fact, we're moving jobs out of this community. I don't want to see a sign that says we do the best heart surgery in the United States. I want to see a sign that says we do the most comprehensive, integrated, coordinated care in this community, that we have half the rate of heart disease. And by the way, when we need to do heart disease, we do the best job, not that our patients are, ATM machines to turn in, to milk, right? I mean, we understand that and we as a large employer have a range of anywhere from $17,000 to $177,000 for the last 6 months of life of our employees. And we look at those ranges. We begin to look at what's happening underneath those kinds of numbers. We see communities where care is integrated and coordinated, where there's robust primary care at the $17,000 range, and we see patients who are happier and have, by the way, lower mortality. And at the $177,000 range, we see patients who are seen as opportunities to milk. And there's no interest in coordinating care. There's no interest in providing comprehensive care. And we've got to change that paradigm and that approach. We do really good partialty care in this country. We have some of the best partialists in the world. People fly from all over the world to join us in having their livers transplanted, having their knees fixed. But there aren't too many of us that have too many of our employees that only have one problem. I mean, by and large, we're becoming more and more concerned about chronic diseases and complications of chronic diseases. And it's kind of like the Olympics. We had the best basketball players in the world, and we put them out on the court and they lost a couple of years ago. Why? Because they didn't know how to team. They didn't know how to coordinate. They couldn't talk to each other. That's exactly what happens to us as buyers of care. We have oftentimes 5 partialists looking at 5 different parts of the body, none of them coordinating in it, none of them talking to each other. We've got to change that. I mean, that's something that we really begin to focus on, like a laser, if we're going to get some concept of control over our system. We as a large employer started a few years ago to look at some of the core elements of what we were buying in terms of the buying proposition of care. And what we discovered was that we were part of the problem. We discovered the enemy, it's us. We didn't really insist on buying a relationship-based, comprehensive, integrated, coordinated care. We seemed absolutely happy to be able to disintermediate our employees by saving a nickel in our benefit costs, right? I mean, we did that in Vermont. We had a case where we had one of our employees, we changed health care plans, right, like all of us do, because we saved a nickel. And one of our employees went to see a new doctor because their old doctor wasn't in the plan. And the new doctor really wanted to look at scientifically based evidence and focus like a laser on the fact that this patient was in real trouble, and started a conversation about controlling hypertension and diabetes. And that patient left and never came back, went to a chiropractor. We ended up paying millions of dollars until they became a ward of the public sector, because that's what happens with end-stage kidney disease. And when we looked at that issue, we asked what went on. What we discovered is there was no relationship, right? There was no way that doc could recover from the fact that they didn't address the core issue for that lady that wasn't centered on the patient's needs. That lady wanted her knees addressed. Her knees were bothering her. And nobody focused on that, so she wandered off. Who paid the bill? We did. It came out of our profit line. So we really began to address those kinds of issues. We as an employer started paying first dollar for primary care. We pay 100% of primary care coverage. We pay for chronic disease medications. We're really on a journey together with the primary care providers to change this proposition, to begin to look at more comprehensive integrated care. When we look at data, those of our employees who are lucky enough to have a primary care provider, to be able to identify by name somebody who is their usual source of care, it costs us 1/3 less money. We have a 19% lower mortality, 12% less likely to be obese, and 7% less likely to smoke. So we really are on a journey to try to transform the way we buy care, the way we interface with the primary care providers to do that. In a change of covenant conversation, a few years ago, we formed the Patients in Our Chronic Care Collaborative to begin to really get at how we could buy care better. Interestingly, the primary care providers responded back to us, well, yeah, I mean, that's the kind of care we want to provide, but you haven't been buying that. You've been buying this other garbage, right? You've been buying episodic, uncoordinated care. You've been buying care that you really don't have access to, right? I mean, only 26% of our employees, I don't know about yours, can access their primary care providers after hours. So we really want to change that. We looked at doing this as a corporate concierge model where we build it ourselves and deliver it. We elected not to do that for two reasons. Reason number one is that 60% of our employees are not in areas where we can actually coordinate the care to be able to do that. And the other is an equity reason. If we can't provide it for all, we don't want to provide it for only 40%. But finally, and I think perhaps the most important reason, as the fourth largest buyer of care, we really wanted to change the entire system. We wanted to be able to buy this not only for us, but for our grandmothers. So the blocking point so far, and we're breaking through that in hundreds of pilots where we're seeing extremely positive results, is this dance between, who pays first. Do the providers change how they practice and demonstrate that, or do we help pay for process to get them there? And in these pilots, we're sort of sorting that out, and we're seeing quite a lot of positive results in that. So what we're seeing as we look at this across the spectrum, and I'm now on slide number 16, is that we are seeing anywhere from 6 to 11% bending of the curve, lower costs in areas where we do this. Vermont, we have 44% of our lives now in a medical home, and it's 11% cheaper. Pennsylvania just reported out to the president, Governor Rundell, 16% lower costs. We're beginning to see adherence and compliance. We saw much better medication management in Pennsylvania. And we've now got about 30 or so pilots where we're beginning to get some pretty early results. We thought the specialists might be a bit concerned about this. It turns out the specialists are actually happy with this care because they have 40% less weeding in their practice when care is better coordinated and integrated. The hospitals are seeing lower admissions and lower readmissions. North Dakota in the 40s, Iowa in the 40s, Michigan in Battle Creek, we saw a 49% reduction in hospital admission for ambulatory sensitive conditions. We're seeing the same thing across the country. Turns out the hospitals aren't necessarily unhappy about that because they don't make much money on chronic diseases, A. And B, they're really differentiating themselves. I visited a hospital in Wisconsin a few weeks ago, and people are driving from 3 counties away to get the better care. Word of mouth that a doc will actually see you, that there's open access, there's flexible scheduling, that they answer your email. Boy, that spreads really fast in rural Michigan and Iowa. And the hospitals that those patients are visiting because the docs are delivering this better care are thriving. Those hospitals that aren't are dying. Glenn Steele, I was with some folks from Geisinger yesterday. He said his biggest concern is, what do I do with the 9 hospitals in my region that I just killed? Because, I'm delivering so much better care than in my system that are occurring other places. We survey our patients, and about 20% are happy with communication with their physicians. I was visiting a hospital a couple of weeks ago in New Jersey, and I said, look, if you survey your patients, I bet you'll find that only about 20% of them are happy with the communication. And this guy raised his hand in the back of the room. I said, we did that, and it's 19%. And I said, yes, that's the issue. You you deliver on that communication model. You enhance communication. You deliver real service, and you'll see your hospital thriving. And if you don't, you'll see it die. In places throughout the country, we're seeing tremendous transformation and differentiation, with delivering this better method of care. And with that, I would like to go to the next slide and introduce my colleague, Ray Fabius, who will be talking about the medical home relationships and collaboration. And I'm really hoping that we'll have a chance to spend a few minutes in questions. Thank you very much.
Like Paul, it is my pleasure to present on this most important subject. And like Paul, I believe that the implications of the medical home have far-reaching influences on the work that many of us do in relationship to corporate health. I do want to recognize Paul and IBM for their leadership role in driving further than might otherwise have occurred this notion that collaborative care and primary care are fundamentally important to the successful improvement in the health status of corporations and communities. For my portion of this presentation, I will be focusing, as Paul mentioned, on, I believe, two underappreciated components of the medical home. One is the importance and the influence of having this trusted clinician-patient relationship, and the other is the impact that medical homes can have on collaboration with others. My first slide speaks to the potential great influence that a doctor-patient relationship can have. Mike McGee, in one of his more recent books, studied the value or the rating of relationships in general in 8 industrialized nations, including the United States. And of course, the most important relationship that people have is with family and friends. But the next most important relationship they have is with their doctor. And that transcends the influence of spiritual advisors and coworkers. But as you can see on the screen, of interest is the notion that pharmacists are high on the list. And in fact, as we'll talk about a little bit later in this session, the notion of a trusted clinician extends beyond just the primary care physician. Every year, Consumer Reports surveys both doctors and patients in terms of their challenges and their level of satisfaction with the healthcare system. And I was quite struck with this report in Consumer Reports in 2007, where it seems as if doctors and patients seem to be passing ships in the night. If you look on the left-hand side, 19% of the patients complain that they could not schedule an appointment within a week. And then 41% of the doctors complained that patients waited too long before making an appointment. So these are two constituencies that are really quite interested in having a closer relationship, and yet the present structure of the delivery system frustrates this potential trusted relationship from getting established. Trusted clinicians and trusted clinical relationships in medical homes can greatly influence the compliance with prevention and health maintenance. As all of you know on this call, we usually focus on 3 levels of prevention: primary, secondary, and tertiary. Primary prevention may include lifestyle changes. Secondary prevention really speak to compliance with guidelines, in particular compliance with screenings so that we can pick up problems early and intervene in ways that can make a difference. And then lastly, tertiary prevention, also known as disease management, can lead to much greater compliance with evidence-based guidelines to minimize the complications of chronic disease. The literature is replete with examples where trusted clinician relationships improves the outcomes, and I will share with you one example in primary care, in secondary, and then finally in tertiary care. One study that's often quoted is a study that was done by Petraska in the year 2000, where he actually demonstrated a significant impact that physicians can have even with very brief discussions around stopping smoking. And in fact, early reports suggested that if doctors spoke to their patients for less than 5 minutes, you could have an 8.4% quit rate at 6 months. Subsequent studies have shown this influence to be even higher, over 10%. Recognizing that the best smoking cessation programs brag about a 20% quit rate, leveraging the trusted relationship between clinicians and patients and getting them to speak together for less than 5 minutes can get you halfway there. Dr. Fox and Dr. Stein published an article in 1991 where they studied many different potential variables to determine what actually gets women to engage in a mammogram. And the most important variable was whether or not their doctors had discussed mammography with them. So once again, the leveraging of the trusted relationships established between clinicians and patients can be quite important in getting people to comply with evidence-based guidelines and take better care of themselves. Lastly, this study done in diabetes care demonstrated that periodic primary care sessions led to much better outcomes in diabetic patients. I'm going to switch gears now and speak more in terms of collaboration with trusted primary care doctors. And in this extension of the issue of building trusted relationships and their influence, I will speak about the impact that trusted clinician relationships can have on disease management, therapeutic management, and compliance with care. Several of you on this call may be familiar with this study that I and others did with Bruce Sherman and his company, his previous company. And in this study, we actually looked at the advantage of delivering a disease management program through primary care providers at the workplace, and compared this to the more traditional telephonic care that is normally delivered in a disease management program. As many of you know, there's a considerable waterfall between the identified patients who may benefit from disease management and the ones that actually participate in the program for a lasting period. And in a meta-analysis that was done by Wendy Lynch in 2006, she determined that about half of the worthy participants in a disease management program were able to be contacted telephonically, and roughly half of those elected to participate, and roughly half of those continued participation 6 months out. In the study that we did, where we looked at delivering the disease management program through trusted clinicians at the workplace, we were able to contact 96% of the worthy participants. 3/4 of those elected to participate, and at the end of a 6-month period, we had 60% of our participants still involved in the program. So we made the statement in these articles that were published in the Journal of Disease Management, which is now Population Health Management Journal. We made the statement that by delivering disease management through the trusted clinicians, trusted primary care clinicians, you could have a 3 times greater participation rate and a 6 times greater retention rate in your programs. We think that this is very important from the standpoint of corporate health, because there's great investment that's made by employers that actually is often not spent well, because in the traditional disease management telephonic programs, there's minimal retention and less than optimal participation. So those of you that are involved in corporate health and in purchasing disease management programs would benefit greatly by having those programs working through trusted primary care relationships. The next slide, which I think is even more interesting, is that when we studied the engagement rates of the worthy participants in the disease management program, those that were working both with the primary care doctors and the pharmacists at the workplace had the highest engagement rates. Those that were working just with the pharmacist had a very significant engagement rate, although much lower than those that were involved both with the primary care doctor and the pharmacist. And even those employees that were using the health center at the workplace just for acute care still engaged at rates higher than traditional book of business. So from my standpoint here, I'd like to make the statement that the engagement rates were dependent upon the depth of the relationship that was established by the patient, and those that had the deepest relationship with doctors and pharmacists had the highest engagement rate. Another study that I wanted to bring forward was a study that we did looking at the collaboration between primary care doctors and pharmacists. Both the primary care doctors and the pharmacists focused closely on their use of antibiotics. And in this collaborative study that was done at the workplace, there was a remarkably higher use of first-line antibiotics and a much lower use of third-line antibiotics, with a savings of about $20 per prescription. And there was no evidence that the greater use of first-line antibiotics, as recommended by the CDC, actually interfered with the outcomes of care. And yet at the same time, there was, as recommended by the CDC, a much lower use of third-line antibiotics, which run the risk of greater resistance, and a savings of about $20 per prescription. Lastly, in a fairly recent article that I published with Dr. Sherman and others, we looked at the compliance rates of those employees who had a a relationship with the primary care doctor and the pharmacist at the workplace in their use of medication compared to the employees who elected not to use the primary care and pharmacy collaborative at the workplace. And in every case, those that were using community providers, I'm going to say more randomly and in a less coordinated way, had a considerably lower medication adherence rate when we studied any one of 25 different groups, diagnostic groupings of medications. In this particular slide, you can see that those patients who were on blood pressure medicines or on diabetic medicines or on heart disease medications all complied remarkably better when they were working with primary care doctors and pharmacists who are working in collaboration. So without going into great detail, there's also a lot of important study showing that collaboration between primary care and behavioral health also leads to better outcomes in behavioral health treatment. This statement made recently in an article in the Annals of Internal Medicine really summarizes my points. Not surprisingly, those patients with the strongest relationships to specific primary care physicians were more likely to receive recommended tests, medication adherence, and preventative care. Two last slides I want to share with you have actually been given to me by Dr. Grundy. One slide shows that when you have patients who have a relationship with a physician, you see significantly higher rates of appropriate screenings relative to patients that don't really have the same level of connection. And in this particular slide, you can see that there's great significance in the difference between the two groups for the vast majority of performance measures studied. Lastly, and this is often underappreciated, is the fact that those practices that engage in developing relationships and coordinating care, those practices that have elected to engage in a patient-centered medical home, actually lead to significant improvements in the job satisfaction of the providers. And by implication, more satisfied clinicians will likely develop better patient-provider relationships. And with that, I'd like to turn this webinar over to my good friend, Dr. Sherman.
Thanks, Ray. It's my pleasure to join my colleagues, Drs. Fabius and Grundy, to share with you additional information about the medical home, and in particular, its relevance to both ACOEM and its membership, as well as to employers. The first thing I'd like to do is share with you some specifics about the medical home model. We have talked at a very high level about the value and the benefits of coordinated care, but I do want to bring home for all of you the specifics about the medical home model itself. And probably the best way for me to start is to just share with you a sentence that I think summarizes the fundamental concepts of the patient-centered medical home, and that is that a medical home is not a building, house, or hospital, but rather an approach to providing comprehensive primary care. Medical home is defined as primary care that is accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. And what you are seeing here on the slide on your screen is a detailed breakdown of the 7 key characteristics that were part of the joint principles of the patient-centered medical home, which was a collaborative document written by the 4 primary care physician organizations in 2007. And just to highlight some of the key features here, and I think Ray and Paul have certainly done justice to a number of these, each patient has an ongoing relationship. There is a team directed, where a physician leading a team of individuals who direct a medical practice. There is a holistic perspective to the care of all of an individual's healthcare needs. The coordination and integration of care, Paul certainly addressed. Quality and safety are key with information technology as an important component to monitor both quality and safety. Enhanced access is another critical component. And lastly, and something we haven't talked about and probably won't address extensively during this call, there has to be an appropriate change in the payment model to recognize the added value that these additional services provide. Going to the next slide, why should employers care about patient-centered medical home? Well, if you think about it, employers have been focused largely on demand-side strategies in their effort to steer people to utilize healthcare services. And a lot of these demand-side strategies in the form of benefits redesign have helped to some degree, but what we know is that despite, for example, having fairly low-cost or no-cost preventive care services within most employer populations, there are surprisingly low participation rates with such components as preventive care services. Employers are now saying, okay, I understand the healthcare system is broken. I can't change what I need to change by just impacting the demand side. It's time to address the healthcare system and the supply side aspect. So employers have focused in a couple of areas, and I will talk about both. One is the patient-centered medical home, and the other, as Ray has previously addressed, is worksite clinic services. But coming back to the patient-centered medical home, why is this a value for employers? There is a business value of better quality health care with improved coordination leading to better clinical outcomes. And as Paul related, the ultimate cost of care, as we are starting to see, and I'll share with you some additional data, is decreasing for patients receiving care in a medical home model. This slide shares a representation of a typical healthcare cost distribution for a U.S. employer, and I was actually able to get some recent data from the past year. The share of primary care costs, which I had been able to isolate from some 2005 data, I can now update and share with you, somewhat surprisingly, that primary care cost now is only between 5 and 6% of overall healthcare expenditures. And I think that number is absolutely critical. What our intent is, and our goal is, and certainly some of the preliminary data that we are seeing would indicate that is if we can shift greater utilization to primary care, we will have a commensurate decline in hospitalizations, in emergency department use, in specialist visits. The net result is the pie is smaller. primary care is a disproportionately greater share of that pie, but the overall size of the pie is smaller. You'll also note, parenthetically, that the pharmacy cost is, or pharmacy component of the pie is actually relatively increased. And that is, as Ray has mentioned, going to be a very likely sequela of improved patient PCMH relationships leading to better medication adherence. So this component of the healthcare cost that is now primary care that is now at about 5%, certainly we can appreciate increasing with the patient-centered medical home. Other models that have attempted to address the healthcare system from a supply side perspective have incorporated various components, as you can see on the left side of this table, but none have addressed them as comprehensively as the PCMH model has. And that is why, to Paul's earlier comments, I think we're appreciating much greater interest because of the extent of alignment between the physician, the patient, other members of the healthcare delivery team, and the purchaser and payer as well. So this is really a broader-based strategy than the other strategic components that are shown here as which really represent pieces of a more comprehensive PCMH model. The pilots that have been ongoing are now starting to share with us outcomes data. Paul certainly alluded to a number of these in terms of some of the initial results. And I think with what has been a fairly consistent report of reductions in hospitalizations, emergency department visits, projected cost savings, the question raised is, when do we stop talking about pilots and when do we start talking about a more broad implementation of a PCMH program? You'll note in the first entry here under Group Health Cooperative of Puget Sound, the second bullet, this was a one-year summary of outcomes. What's important to note here is that the additional cost for this program of $16 per patient per year was basically offset by reductions in overall healthcare expenditure. So there was effectively no net increase in total cost. And what we are hearing from preliminary results for year 2 is that there have been significant further reductions in healthcare expenditures. So this model in this particular location is actually generating a net savings, which is certainly what we anticipate seeing. When we think about some of the issues that have arisen for employers with respect to the implementation of a patient-centered medical home model, and also how the occupational environmental medicine physician can be involved, employers have, I just want to hit on each one of these. Employers are in the minority when it comes to PCMH implementation. IBM has certainly been a leader in moving this initiative forward. Kellogg is certainly doing so in Battle Creek, Whirlpool in Findlay, Ohio, and there are others. This change in employer strategy and the adoption of a PCMH model certainly benefits from a physician corporate medical consultant who can add expertise to what is becoming an increasingly complex healthcare delivery system. And for many employers, this transition from dealing with demand-side issues where employers have control over benefits to dealing with supply-side issues, physicians can play a significant role in terms of helping employers understand how to move forward. Employers also, understandably, may struggle with having to deal with location-specific implementation of PCMH versus implementing a one-size-fits-all benefit design change that may be broadly implemented across multiple locations. Again, there are opportunities to quantify and demonstrate the value proposition in various employer communities and use that as a basis for advancing PCMH sequentially among various employer locations. One of the issues that I think many employers are concerned with right now is the focus on near-term costs. There's certainly an issue here with respect to the additional reimbursement for PCMH that employers may have to face when implementing a new PCMH program, and as such, physicians can help to provide additional education and better understanding about the value of these kinds of investments in health and productivity and the timeline as we're seeing it now for a return on investment. And lastly, as I started the discussion on this slide, physicians in a medical consultant role to employers can certainly help to provide substantial resource information and expertise regarding PCMH implementation. With respect to worksite clinics, this is a very interesting area of consideration right now. I think for many employers that have full service primary care, they essentially have a variation on a PCMH model, and that is if full service primary care is provided and that care is accessible after hours, and there are certainly some large companies like Disney and Toyota that have implemented this kind of a model, and in many ways there are a number of lessons that can be learned for community physicians implementing PCMH programs that they can learn from these worksite clinic PCMH models and some of that data Ray shared with you. If not, those worksite clinics can, if there is an effective integration of the on-site clinics with community services, those clinics can fragment care additionally. And I think one of the areas that is worthy of mention is chronic condition management. How are the on-site clinics helping to support chronic condition management, or are there duplicate paths within the healthcare system? And this is something that I think a year ago, if you had approached a number of worksite clinic providers, the focus was on on-site care delivery and looking at the market value of those services. Now I think the blinders are off, and those same vendors are now starting to look more at how worksite clinics can actually support community PCMH offerings. There is, as I think one can appreciate, looking at a number of different employer clinics and a broad range of extent of integration between on-site services and what is in the care that's being delivered in the community, all the way from standalone clinics where there is more of a focus on acute episodic care or preventive care, all the way to clinics that are more fully integrated with effective communications. And I think what we need to see for the sake of supporting community-based both primary care and PCMH is a more conscious shift toward more effective integration of worksite services and those of community providers, again, particularly primary care, and better yet, if there are patient-centered medical homes within the community, more effective integration with those services. Just as an aside, one of the things that we are starting to look at is using the on-site clinics in the setting of a community-based PCMH to provide support for chronic condition management in a very organized and structured way. After all, where do individuals spend the bulk of their time? They spend it in the workplace. And having the worksite clinic serve as a bridge to the PCP seems to make a whole lot of sense. From the standpoint of a practical operational integration, for those of you that have worksite clinics or are involved with clinics that are providing healthcare services, think about how your services can be more effectively integrated with an individual's primary care provider or PCMH. Bear in mind that while we are certainly seeing a movement and a pretty strong movement toward PCMH, the mere fact that so many people currently don't even have an identified primary care provider driving participation and use of primary care services to provide at least the starting point for medical home integrated comprehensive services makes a great deal of sense. So from the standpoint of whether it's worksite clinics or community-based occupational health clinics, it certainly would encourage identification of community-based primary care and facilitate communication in terms of playing a supporting role for that primary care provider. One of the other things for the sake of ad hoc communications with primary care, another area where we are focusing is to ensure that there is a formal process to ensure ongoing communication with between the worksite clinic and each individual's primary care provider, so that that information flow is consistent and regular to facilitate management of the care by the PCP. The other thing, and this probably has a little less to do with patient-centered medical home, and that is in the worksite clinic, there may be other employer health benefits offerings that the worksite clinic can support, as can the PCP, and we're hearing greater PCP or PCMH interest in learning about what other employer health benefits are available, so that not just the worksite clinics, but also the community PCPs and patient-centered medical homes can support the use of those services. From a clinical practice standpoint, as I mentioned before, supporting the PCMH with chronic condition monitoring, and to some degree there may be a way to more effectively integrate the worksite clinic in that it may be providing services that the PCP is not, that are complementary. For example, many employers now have on-site health coaches, and there appears to be an increasing interest in having more on-site presence of ancillary healthcare providers and a facilitated communication between the worksite clinic and the PCMH or the PCP can help to provide, albeit a more diffuse or decentralized scope of services that the PCMH can provide, but in total effectively represent a comprehensive suite of PCMH services. And lastly here, there may be some opportunities at some point to give consideration to a payment structure. Right now, one of the models that is discussed is for PCMH is a payment incentive to the PCMH providers for achievement of particular clinical outcomes. One could certainly propose that outcomes-based reimbursement is perhaps a shared payment that goes to, in some proportion, to both the worksite clinic and the PCMH based on achievement of the desired clinical outcomes. Another thing to address is value-based insurance and how it fits relative to PCMH. And I am leading you through a series of small logical steps here, but the bottom line is effectively that if an individual is incented to use a high-value service, use of that service will increase. And since PCMH, based on the data that you've seen thus far and what's in the literature, can only be considered a high-value service, that incorporating some kind of value-based design to drive PCMH use will be beneficial for employers. And this is precisely what IBM has done and Paul has described to you earlier in the presentation. That is that IBM has no copay for primary care. In other words, primary care is free. So this is one way to think about integrating a PCMH, a supply-side strategy, with value-based insurance as a demand-side strategy. Taking this one step further, and again, there may be opportunities for a more detailed actuarial analysis to evaluate some of these considerations, but in addition to copay reductions or waivers for medical home visits, there are opportunities to consider similar reductions for PCMH referred services, implying that the decisions for either treatment or diagnostic testing have originated as a result of a collaborative relationship between the patient and their medical home clinician, not as a result of a patient-generated request. One of the things I think that's important to point out, and we haven't really talked about it to this point, is the fact that the PCMH is not managed care. This is really best in the vernacular of managed care, where the primary care physician was a gatekeeper. We are talking more about a collaborative care model where the medical home clinician is the gateway. And that's why using or accessing the PCMH as a gateway to further care may well justify copay reductions for use of these additional services. Additionally, and in part to drive PCMH provider selection and use considerations for contributions to a health reimbursement or health savings account, and also for individuals that are compliant with recommended care in accordance with PCMH clinician treatment. Perhaps they are in a position to derive benefit from additional HRA, HSA contributions, or for some employers that are using a tiered benefit design to be placed in the more favorable benefit tier as a result of their compliance. So thinking about ACOEM's role with respect to PCMH, I think there are a number of ways where physicians in ACOEM can help to foster the adoption of PCMH on a national level, particularly for corporate medical directors, for occupational medicine physicians who do have interaction with employers. There are major opportunities to help educate employers about the business value and the health value of PCMH and start driving market demand. Health plans, if I may generalize, may not be so willing to move forward unless there is perceived market demand. And this is certainly one way that physicians can play a substantial role. There are also opportunities, as noted here. There is so much medical literature right now about the value of PCMH. Being able to convert that to business language for employers, whether that's through individual employers, through health coalitions, through other regional business meetings, there are ample opportunities to provide education and create more of this market demand to drive PCMH implementation. ACOEM has certainly expressed commitment to PCMH, and in fact, ACOEM is one of a number of important physician organizations that have formally signed on supporting the principles of the PCMH, and through a House of Delegates resolution that was sponsored by the corporate medicine section, this resolution was passed by the House of Delegates. And I think, as one can appreciate, with Paul Grundy being the president of the Patient-Centered Primary Care Collaborative, we certainly are in a leadership position in one of the preeminent organizations that is driving patient-centered medical home adoption. So how can ACOEM members become more involved in PCMH activities? One of probably the best places to go for information on the internet is the Patient-Centered Primary Care Collaborative. There is a wealth of information there on a newly redesigned website, and I think you'll find it very helpful with a number of white papers, other resource materials that will facilitate your learning about PCMH and how it can be implemented at on a community or employer-specific basis. Additionally, I certainly encourage everyone to understand regionally what is happening, whether that's through health plans, medical societies, hospitals, physician associations, business health coalitions or other associations to understand what kind of medical home activities are ongoing. It's interesting how rapidly there is uptake of PCMH as a strategy that really has broad-based support, as you heard Paul say, and that is leading to perhaps more rapid uptake of this as a strategy because of a consensus basis for everyone's interest. I've included here a series of reference documents that have been published by the Patient-Centered Primary Care Collaborative. Each of these is available for download from the PCPCC website. This one explores issues related to health IT capabilities in support of the patient-centered medical home. This next one is a purchaser guide for employers to provide really a number of the practical components of implementing a PCMH program. This proof and practice document, which was published last fall, is a compilation of demonstration projects that were previously published by the PCPCC, showing a number of the specific aspects of the programs, how they are implemented, who the stakeholders are, in additional details regarding evaluation methodology and metrics tracking as well. And then the last one that I have here for you is a document that supports consumers. So where the earlier documents are more employer-based or perhaps multi-stakeholder-based, this one focuses on consumers and provides resources to facilitate consumer engagement, not only with patient-centered medical home, but with primary care as well. It's been amazing to me hearing stories about how few people actually have selected a primary care provider. And again, while we wait for more broad implementation of PCMH, certainly encouraging people to connect with a primary care provider is of great value. So I want to wrap up my part of the presentation with just some final thoughts. We are clearly seeing rapidly growing interest in adoption of medical home model. There is certainly a great deal of information and more emerging literally daily, showing that PCMH is an effective means to increase healthcare quality and improve appropriate utilization with effective reductions in healthcare, inappropriate healthcare utilization, and we're seeing reductions in healthcare cost as well. It is certainly clear from my perspective that OEM physicians are in a great place to, because of their involvement with companies, better understanding of corporate medicine and the business aspects of health, to really guide employer efforts to adopt and incorporate PCMH strategies as part of healthcare quality improvement and cost control efforts. OEM physicians can also be involved with multi-stakeholder efforts that are occurring literally across the country in communities to get PCMH programs implemented. And finally, worksite clinics can serve to support both community primary care and PCMH to leverage the value of those medical homes and increase value to employers. I leave you with a number of resources. The bulk of these are related to physician-facing websites that can help physicians understand how to become medical homes. We've talked about primary care providers being the major stakeholders here, but certainly other physicians as well may find it appropriate to be considered as a medical home. With that, I will stop. And before we get to questions, I'm going to turn the presentation over to Sandy and to Ray to review the CME questions.
Thank you so much, Dr. Sherman. In order to document the CME continuing education credit with this program, we'd like to address a few questions. And we're just going to read them. We'd like you to think about your answer, and then Dr. Fabius will address those. Number one, from the employer perspective, patient-centered medical home has appeal because of all of the following except A, the potential for lowered healthcare costs, B, improved compliance with treatment guidelines, C, increased near-term implementation costs, or D, enhanced workforce productivity. While you think of your answer, Dr. Fabius, could you please address this question?
While implementation costs will increase the short-term expenditures for employers, this is not one of the reasons for the appeal of implementing patient-centered medical homes. So your answer is C.
Thank you. Question 2. Care provided by patient-centered medical home is likely to improve clinical outcomes for chronic conditions because all of the following except A, improved patient-clinician relationship, B, patient incentives, C, more effective communication between healthcare clinicians and patients, or D, improved tracking of disease-specific preventative care services. Dr. Fabius?
In the traditional modeling of patient-centered medical homes, patient incentives are not included. While some enlightened companies like IBM have engaged in forms of patient incentives to entice their employees and covered lives to participate in patient-centered medical homes, the answer here is B, because that is the one exception to the conditions of a patient-centered medical home, and it's likely ways that it improves the clinical outcomes of chronic care.
Thank you. And I would like to remind everyone to please submit your questions electronically. We will be addressing those questions as time permits after we address these final 3 CME questions. Dr. Fabius, data from patient-centered medical home pilots thus far have shown to result in all of the following except A, improved patient adherence in recommended treatment, B, enhanced patient and provider satisfaction with care delivery, C, long-term increases in healthcare costs, D, decreases ambulatory care-sensitive hospitalization rates, or E, decreased emergency department utilization rates. And the answer?
Thankfully, the answer is C. Long-term increases in healthcare costs have not been shown, but all the others have been shown. Healthcare costs, particularly for hospitalization and emergency room use, have declined in the patient-centered medical home pilots.
Question number 4. Worksite clinics can reasonably support medical home practices by all of the following except A, enforcing the importance of medication adherence, B, enhancing access to clinicians for chronic condition monitoring, C, ordering changes to treat regimens, D, providing lifestyle behavior change coaching. And the answer is?
Again, here the answer is C. Independent medical treatment by worksite clinics can further contribute to the fragmentation of care and interfere with care coordination provided by patient-centered medical homes. So C, ordering changes independently to treatment regimes would not be supportive of medical home practices.
And finally, the development of trusting relationship between patients and medical home clinicians is associated with all of the following except A, better compliance with preventative care services, B, better compliance with chronic medications, C, more effective treatments to target goals, D, improved patient satisfaction with care, or E, all of the above. And the answer is?
Well, we're proud to say that the answer is all of the above. A closer patient-provider relationship appears to be beneficial from a number of perspectives, including all those listed here.
Well, at this time, we'll go ahead, Dr. Sherman, and address some of the questions submitted. And while you're answering your questions, we'll pull up a few overall evaluation slides to get some of your polling results.
The first question, Paul, I'm going to steer to you, and that pertains to the question of whether there is, or if you could comment rather on the relationship between primary care use and lower healthcare costs and lower mortality. Is that an associative relationship, or is it a causative relationship? And can you comment on the information that's in the literature with respect to association versus causation for the value of primary care services?
Yeah, this is Dr. Grundy. Thank you for that question. We think in looking at the data that it's associative, but when we begin to look at broad numbers of studies around the world, we think that it's also causative for all the reasons that we just described in the medical home. It's causative really if primary care is set up and established to deliver comprehensive, integrated, coordinated care. In places of the United States and certainly places in the world where that occurs, we definitely think that that's a great foundation. When I travel the country, however, I do see places, and I talk to extremely demoralized primary care providers who clearly see themselves as part of a milking machine that's really set up to feed coronary arteries, whether they need to be stented or not, to be stented into systems that do that. And you know, that's the article written by Atul Gawande between Grand Junction and McAllen, Texas.
Thanks, Paul. Ray, do you have anything to add?
Oh, I think that's well answered.
Okay. Ray, the next question is for you. One of the listeners has commented that he or she agrees that the on-site clinic should be directed towards supporting chronic disease management and facilitating communication with primary care physicians. But the viewer raises the question of workers' compensation, which requires skills in the areas of return to work and causation, and how should that be integrated into an overall PCMH program?
It's an excellent question, and one that we didn't delve too deeply into. But as you start to look at some of the more, I'll say, traditional services that occupational health has expertise in, such as medical surveillance examinations, disability management, and workers' comp management, you may see a shift from a more heavy reliance on the medical home to a more heavy reliance on the occupational health resources that are available at the employer site, or at least within the employer's contractual relationships. At the same time, we all believe that a closer relationship between those providers that may be assisting with occupational health and the primary care doctor will yield better compliance and a smoother process and better outcomes. In particular, with regard to workers' compensation, the better understanding, for example, of the patient's baseline status can be perhaps best provided to the clinicians analyzing a case by the primary care provider and the medical home.
Thanks, Ray. Paul, anything to add?
No, I think that was well covered. Thank you.
Great. A question for all of us. A solo physician has really concerns that PCPs are under siege from nurse practitioners and physician assistants, and how can they effectively fit into a PCMH model, recognizing the additional training and expertise that a PCP may have to warrant a pay differential?
This is Paul. Where I see this working well, I was just visiting in Utah, where there's a program called Care by Design. It's now a number of years old. The physician's time and effort is focused on two areas of difficult diagnostic dilemmas and relationships. Most of my employees want to have a relationship with a physician and value that relationship. In fact, over 70% say that that's who they prefer to have that emotional attachment to, which I think is so key and important. You see, as physicians and as healers in society, we have a really special position, and most of my employees want to have the folks who are trained at the highest level to be who's thought of as their healer. I think that's a very unique position that physicians have. That being said, there's some percentage of my employees who are happy to have their first contact, with somebody who is not deemed a physician. It could be a nurse practitioner, and I think PAs are yet in a different category. And where I see this working really well, like again in Utah, it's really a team-based approach, and the focus is really on the patient and not a scope of practice issue. And when that occurs, even in practices where states where nurse practitioners are licensed to practice independently, they don't. They don't feel comfortable in that role. As a general rule, there are not very many of them because they're really trained very differently. However, they do, again, I saw this in Utah, they do a fantastic job, and perhaps even a better job than physicians do, around the whole area of education and care coordination, because they really come out of a field of nursing, right? I mean, it's a different concept, a different scope of what they do. Clearly, together, we make a better team. Clearly, we're all going to be needed. And I don't think that we as physicians should worry about our role and should even necessarily fight about it within the scope of practice fight, because I think the market, again, when I survey my patients, most of them want to have their primary relationship as their healer with a physician. So I don't see it really as a big issue. Thanks.
Ray, your comment?
I agree with the points that Paul made, and I would perhaps just take it from a little bit of a different direction and actually build on points that he made during the presentation. The intent of the patient-centered medical home is to actually build a team of clinicians and then to use the right clinicians for the most appropriate services. There are, for example, very good studies to show that nurse practitioners and physician's assistants are often actually better at communicating detailed patient education information than the physicians. And so, for example, perhaps as it relates to training patients to take better care of themselves, that may be time that could be better invested by nurse practitioners who are part of the team in a medical home versus the primary care provider. As we now have experienced the passage of the new health reform bill, there will be 32 million new covered lives entering into the system for primary care services. With the present demand and the future demand for primary care services, I would think that the majority of primary care providers would welcome the inclusion of nurse practitioners and physician assistants to their teams rather than to consider them as competitions for care and services or feeling as if they're under siege.
Ray, you took the words right out of my mouth. I think the key is a team-based approach to care delivery. Let perhaps people that have, individuals that have less training provide those services for which they may be particularly better trained and uniquely well suited, such as patient education or acute care for minor concerns, and leave the physicians to provide those high-value services that rightfully deserve more appropriate remuneration. I think we have time for one last question, and I believe this one is related to worksite clinics. Ray, with an increased focus in non-occupational services provided in the workplace, how do you address the perceived fear of employees that the medical information that's gathered could adversely affect their continued employment or promotion?
Well, this is an excellent question, and is one of the reasons why most on-site health centers do not experience 100% penetration or participation by the employee base. Despite the best efforts of reassurance, there will be some people who will opt to not utilize the workplace health center in favor of community resources for fear that their health records may be exposed to their employer. At the same time, for those of you that are involved in workplace health centers, it's fundamentally important that whether you're providing the service yourself because you as the employer hire physicians or nurses to provide the service, or whether you're using an outsourced vendor such as my previous company, CHD Meridian, now part of Take Care Health Systems, you must monitor and you must provide oversight so that it's quite clear that the medical records are private and secure. I will tell you that for those of us who've spent time engaged in this, when I was the global medical leader for General Electric, I was responsible for 230 health centers in 29 countries. A very important part of the effort of workplace health centers is to keep the information private and secure. And that's true whether, again, it's sponsored by the employer directly or it's provided by contracted vendors.
Thanks, Ray. Well, I think we are out of time. Sandy, I'll turn it back over to you.
Great. I'd like to thank all of you for your attendance and thank our presenters for their valuable presentations today. This does conclude today's program. You may disconnect.